Welcome everyone. My name is Greg Thompson. I'm a general surgeon that just completed my surgery residency training in Birmingham, Alabama, and I just recently joined Cullman Regional Medical Center. I have a strong interest in robotic surgery and doing numerous procedures using the robotic platform. But before I get into all this, I first want to give a thanks and a shout out to Cullman Regional Medical Center for hiring me on, as well as the Cullman community for accepting our family so quickly into Cullman. So let's get started. First, I'm going to tell you a little bit about myself, my background, before we move forward with talking about robotics and hernias in general. I was born and raised in Alabama, just about 30 minutes north of here in Madison, Alabama. I grew up with a sister that's 3 years older than me. She's a nurse practitioner in Georgia now. And then I basically grew up outside playing whatever sport was in season. My two passions are football and baseball. And I still remember times coming back to Cullman really and playing baseball tournaments here, numerous times actually. And I've already seen since being here with my 5-year-old the amount of baseball fields throughout the city, so it's been pretty amazing to see. I began dating the woman I'd eventually marry my senior year of high school at Bob Jones High School. We eventually got married after college, but we both ended up going to Auburn together and graduating from Auburn University. While there, I guess you know where my allegiance lies as well now if you didn't see it on my badge. But while at Auburn University, I worked as a firefighter and EMT throughout college. Helped me put me through college actually. And then, like I said, after I graduated, you can see my graduation picture here, and that's a firefighting photo as well. After I graduated, we went to South Alabama for medical school. So we'll move on. We got married in between college and going to South Alabama. And while there, the 4 years I spent in Mobile, we had our firstborn child, Caleb, there my final year in Mobile. Once we graduated medical school at South Alabama, we came back north to Birmingham, and I did my general surgery residency there for the next 5 years at Brookwood Baptist Health in Birmingham. While there, we welcomed our second son, Tyler, as well, to the family, and they're now 5 and 3 years old. And during my time in Birmingham, you can see this picture on the right is actually the very first time I used the robot 5 years ago when we started our training with it. And since then, I've been a part of over 350 robotic cases. So going forward, this is the final picture I have from my training. I was elected to be the ambassador for the program in the American College of Surgeons while I was in a residency program. I also received the Hugh Linder Award in recognition as a top surgery resident at my residency program in Birmingham while I was there. And after all that, we knew we wanted to get back to North Alabama, smaller town feel. Cullman was perfect for that, and they gave us an offer, and we jumped on it. So we're super excited to be here. You can see this is usually after a residency program, once you finish your training, you get a big ceremony at a nice restaurant, that sort of thing, but COVID kind of snapped that off, and we ended up taking they gave me my plaque and sent me out the door real quick with one picture, and that's about all we got due to COVID, but it's still a great training there. And this is just the most updated picture I have of my boys now. They're 5 and 3, my wife, Kelly. So now let's talk about surgery. Before we can get into robotic surgery, we kind of got to tell you where we've come from with surgery. So as far as we can remember, surgery's always been done what we call open surgery. So that means a long incision, painful incision. You had to use these long incisions to get inside the abdomen to retract things to be able to see as good as you can at that point in time. And these are always fraught with complications. You'd have infections, you'd have hernias, which we'll talk about later. They're extremely painful afterwards. You had these long scars. And then as time went on, as technology developed, we developed minimally invasive surgery. And that entails what everybody knows now as laparoscopic surgery. So that's the long metal poles with a camera lens on the end, and they basically make incisions through these tiny little poke holes, as you can see here and here, and you're able to work on that same pathology, whether you're taking a gallbladder out or appendix or colon, through these small little poke holes versus making this large incision, and patients did drastically better with this. This really caught on in the 1990s, and since then it's only really gotten better with the advancement of technology. And so that's where the majority of people still lies with laparoscopic surgery. And then which brings us to what we call robotic surgery. So in 2000, the Da Vinci robotic surgery system, which is made by Intuitive, was FDA approved for general surgery, general laparoscopic surgery. And since then, it's only improved so much so that it's now the most advanced platform for minimally invasive surgery on the planet at this point in time. In regards to what the term robotics means, I know when people hear robotic surgery, they think of they can either get excited about it or they freak out about it, and they think, oh, is this a robot in the room basically, and the surgeon's in the corner, the robot's doing my entire procedure? That's not the case at all. The way you should think about this robot is really it's an extension of the surgeon's hands. It's just another tool the surgeon uses to give you a better procedure. This picture that you see here is the actual robot that we have here at Cullman Regional. It's the 4th generation Da Vinci robot, the newest one that is on the market at this point in time. It is an excellent machine. It allows me to do things in operations that you cannot do laparoscopically, and I'll kind of get into that. There's 3 really big ones that it helps out tremendously with, and I'll talk about that next. So one of them being what we call 3D vision. So laparoscopic surgery, your surgeon's working through two or three little poke holes, and they're seeing a screen in front of the patient, and it's a 2D, just like you'd see a normal TV screen. But with robotic surgery, you're sitting at a console and you actually see in 3D everything you're looking at in the abdomen. So it's a much better vision that you're looking in while you do this. And then what I really love the most is what's called the endo-wrist technology. So I'm going to try to explain this. So with laparoscopic surgery, if you come in, you can imagine the patient has on the patient, the surgeon has 2 arms, and he can only do this with his graspers. So he manipulates in the abdomen, doing this back and forth. But with the robotic arms, you're able to actually have articulation just as you would if you had your hands in the patient's belly, and the graspers can manipulate like this in 360-degree motion more than your wrist actually can in the abdomen. So that right there is the game changer for the robot versus laparoscopic surgery, and it's made us be able to do things robotically that were never thought possible laparoscopically. And it makes a lot of things that you do laparoscopically 10 times easier robotically, to be honest. And then the third one is basically the intuitive motion control. So I'll show you a picture here. You can see this is actually the robot where it would dock to the patient. These are the arms of the robot coming in. So you actually enter the surgeon enters the belly the same way he would do laparoscopically. And then once he gets those ports in, he then docks the robot to the patient. After he docks the robot to the patient, he steps over to the robotic console and sits down at the console. And he is out now viewing this console 3D through here, and using his hand motions with his fingers, this robot will do exactly precisely what he does at the robotic console to a centimeter, to a millimeter. So it's absolutely amazing what you can do with that. And like I said, you can rotate your wrist completely, you can move your arms up and down, and the robot will only do exactly what you do with that. And then this far right is actually the power tower. It actually has other vision so people in the room can watch it as well. It deals with your HD vision, and also has power sources for whatever else is needed to be used during the surgery. All these updates basically say the Da Vinci robot has had a dramatic increase in about the last 5 to 10 years for general laparoscopic surgery. It's taken on dramatically in the last 5 years, really, and I'm really excited to get that going here in Cullman as well. So I'm going to show you now is 2 videos. The first one's going to just kind of explain better what the robot does, better than I can, and the second one's going to explain what a typical operative day would be if you came in for a procedure with the robot. So I'm going to see if it pops up for me. There we go.
We've integrated what we've learned from our customers and what our design teams have invented, and now we're proud to present the Da Vinci Xi. The Da Vinci Xi is our 4th generation of Da Vinci system, and it has in it over 20 years of learning how to enhance surgical performance by creating a natural extension of the surgeon's eyes and their hands.
This new product features fast 4-quadrant surgery, substantially improved vision, and is a scalable platform for all our advanced technologies. The overhead boom allows the arms to rotate as a group, and this frees up valuable space inside the surgical field, allowing unobstructed access to the patient. This is all enabled by smaller, lighter arms with extended range of motion and improved reach inside the body.
Making the system much easier to use was a primary focus of developing the Da Vinci Xi. Docking is facilitated by a laser targeting system. Point the endoscope at the surgical site, press the targeting button, and the system will configure itself into the optimal position for the procedure.
The new endoscope is much easier to use. No more draping, calibration, white balance. You just plug it in and go. With this new architecture, you can put the scope in any one of the arms, and it gives you a lot more flexibility and setup.
At Intuitive, we strive to create the safest, least invasive option for surgery. And we believe deeply that minimally invasive surgery should be a standard of care, and we work hard every day to make that a reality.
So that's the first one that kind of has an Apple feel to it to me. I could watch an iPhone commercial. And this one's going to be more so what you can expect the day you come in for a one-day surgery and what you'll see around you.
Whether you or someone you love is preparing for surgery, with Intuitive's Da Vinci surgical system, it's helpful to know what to expect. This video will give you an overview of your surgery day, what the Da Vinci Robotic-Assisted surgery system is, and how it's used during surgery. On the day of your surgery, you'll arrive at the hospital or surgery center based on the instructions you received from your care team. Once you check in, a care team member will take you to a room where your surgery prep will begin. Your surgeon and other members of your care team will come in to see you, answer any questions you might have, prep you for surgery, and go over your surgery timing. When it's time for surgery, you'll be brought into the operating room. There will be several people in the room. Each person plays an important role in your surgery. Before your surgery begins, you'll receive medicine to help ensure you don't feel any pain during surgery. Also in the room is the Da Vinci surgical system. A good way to think about it is the Da Vinci is a high-tech extension of your surgeon, and it's your surgeon who is always in control. The Da Vinci is made up of 3 separate parts. The console is the control center, where the surgeon sits to perform the operation. The patient cart holds the camera and surgical instruments your surgeon controls from the console. The vision cart manages communication between all components. It also has a video screen that lets the care team view the surgery as it's happening. What's nice about robotic-assisted surgery with Da Vinci is that it's a minimally invasive option. So the surgeon works through small cuts in your skin called incisions. They range in size from 8 to 13 millimeters, which is about the size of your fingertip. With traditional open surgery, the surgeon must make a cut large enough to see the area and fit the surgical instruments. Through these smaller openings, your surgeon will perform the surgery using a camera and long, thin instruments that can move like a human wrist. The Da Vinci camera allows the surgeon to see in 3D and magnify to 10 times its normal size, so he or she can see details more clearly than with the naked eye. It would be like looking at a quarter the size of a dinner plate. In addition, your surgeon can make precise and steady movements from the console with the Da Vinci system. When surgery is complete, your surgeon closes any small incisions with a few tiny stitches. The care team then moves you from the operating room to a recovery room. You'll stay in the recovery room until you wake up. Before you have surgery, your care team will let you know how long they expect you to stay in the hospital. This depends on the type of surgery you have. Now that your surgery is complete, you are joining patients from around the world who have collectively had more than 6 million surgeries done with Da Vinci. That means a Da Vinci surgeon starts a procedure every 30 seconds. So by the time you finish this 5-minute video, another 10 Da Vinci procedures will have begun. One reason there are so many Da Vinci procedures is that the Da Vinci system is used for a wide range of surgeries all over the body. We hope this video has given you an introduction to robotic-assisted surgery with the Da Vinci surgical system. As you or someone you love prepares for surgery, we encourage you to ask questions of your doctor and care team and follow their instructions both before and after surgery. You can also visit our website at davincisurgery.com. There, you'll find information about your care options, the Da Vinci surgical system, and specific surgeries that can be done with the Da Vinci. You'll also find questions you might ask your doctor as you or a loved one prepares for surgery.
All right, so you'll kind of got a better understanding. That does a little bit better than I do in regards to describing what the robot is, but two great videos on that. And those videos will actually be linked to this on Facebook, so you'll be able to click on those yourself and rewatch those if you have more information that you need. So going forth, we've talked about the robot, how it's used. Now let's talk about what it's used for. One of the most common procedures we do or deal with are hernias and hernia repairs. So I was going to just discuss hernias and kind of give you a better understanding of those, so you kind of understand one of the most basic things that we do with these. So what is a hernia? A hernia is a weakened area of the abdominal wall that allows other tissues previously held in by that area to protrude through and sometimes cause problems. So if you think about it, you have tissues, different layers of tissues on your abdominal wall, and over time, these tissues can get weakened and allow other things to protrude through. This could be intestines, this could be different organs. Sometimes you're actually born with these congenital defects, as we'll talk about with groin hernias. Sometimes they come on over time as tissues get lax, tissues get weakened, or tissues get injured from previous surgeries can actually cause it. So we'll talk about the three main areas where this can occur. We'll talk about groin hernias and the different types. We'll talk about ventral hernias and incisional hernias. And then just a fact that approximately 5 million Americans right now are walking around with a hernia. 2/3 of those are going to be groin hernias, and 1/3 will be ventral hernias as well. So here's just a basic cartoon showing you kind of what the hernias we're talking about are. So when we talk about groin hernias, what do we mean? There's really 3 different types of groin hernias, and 2 of those are different types of inguinal hernias that we see here, and the third one's going to be femoral hernias. Those are all lumped in as groin hernias. And then the rest of them, when we say ventral hernia, it really means abdominal hernia. So anything on your belly wall is what we call a ventral hernia. And then basically they're really described based on where they are on your abdominal wall. So umbilical hernia, as it says, is going to be right at your navel or your belly button. You can have lateral hernias that are not off the midline of your belly to the side. And then you can have epigastric hernias, which are actually above your belly button, below your sternum. And then we have also what we call incisional hernias, which are usually after you've had a previous injury or an incision in that area from a previous surgery. Anytime you have tissues that are cut on, when they heal back together, they're never as strong as they were initially. So they're usually about 80% as strong as they once were. So they can lead to weakening in that area and actually prone to more hernias in those spots. So groin hernias, we'll talk about these first. They're the most common by far. So there's 2 main types. There's inguinal and femoral hernias. I'll give you a quick picture of what I'm going to talk about here. So if you think about it, if you touch your hip bone and go down to your pubic bone, there's a ligament that goes there. That's right, your groin area is. That ligament is called the inguinal ligament. And within that ligament is what we call a canal. There's a canal where things come through there. If you're a man, it's your spermatic cord going into your testicles and your scrotum. And if you're a woman, that's your round ligament going through there. Along with that, it's going to have blood vessels, veins. You'll have nerves as well. And so that's a very high real estate area to work with. And so right where that area, what's called the internal ring, is the connection from the inside your abdomen to that canal that goes to your scrotum for men. And basically, when you have an indirect inguinal hernia, it's actually a congenital defect you're born with that over time gets larger and allows for herniation through that hole that should have closed off on its own. It just failed to do so. And so you'll actually get a hernia down this canal, and that's called an indirect hernia. The next one, you see this triangle right here. It's called Hasselbalch's triangle that I'm circling. It's Hasselbalch's because he's the one that found it, so he gets to name it. But that's a hernia, and that triangle is called a direct hernia. So that's actually a hernia that's a weakening of the tissue in that region, and it protrudes through the back side of the canal. So it's not going through the canal like an indirect inguinal hernia. It's coming directly through the back side and pushing into it. That's what we call a direct inguinal hernia. And then if you see here, this line right here, the inguinal ligament, below that you have a potential space as well, where your vessels come out and feed your legs. You have a potential space there called a femoral hernia canal. And so that's where you can get femoral hernias that protrude out, and that's more common in women. So let me go back and show you a couple more. So with the groin hernias themselves, they're the 3rd leading cause of ambulatory care visits for GI complaints. The estimated prevalence is 5 to 10% of the U.S. population has a hernia or had one repaired. Men are 8 times more likely to develop a hernia and 20 times more likely to need it repaired than women are. And lifetime risk of developing a hernia is 25% in men and less than 5% in women. Sorry, guys. Risk factors for this. older age. As you get older, your tissues get lax, they get weaker, and you're more prone to these. Male sex, Caucasian race, chronic coughing. Chronic coughing leads to chronic straining. Pressure in those areas can lead to it. Strenuous exercise and activity can lead to it over time as well. Heavy lifting, that sort of thing. Chronic constipation leads to chronic straining, so that is another risk factor. Previous injuries, abdominal wall injuries, injuries to that area can lead to it. Pregnancy can lead to it. Smoking, you've probably already heard smoking is not good for any part of your body. You heard about your lungs and your heart already. It's everywhere else too. Smoking inhibits tissue healing, and it makes tissue breakdown more. So smoking is terrible for any kind of repair of any kind of surgery in general, but also for hernias, it makes you more prone. And then prior hernia repairs also make you more risk for a recurrent one. So signs and symptoms of a hernia. Things you most likely will present with, patients often come in complaining of a bulge in their groin they feel. This bulge can be painful, it can be painless. They can be very variable in the size as well. Sometimes a small acute hernia is going to be a lot smaller and it's going to be painful versus somebody who has a very large hernia that's been there for a long period of time, has a large hernia hole, as you can see right here on this side. If it's a larger hole, you can allow for actually a lot more intestine to protrude through there. And I've had patients come in their scrotum having basically a grapefruit size scrotum from intestines protruding through there. Those are your more chronic hernias that over time just get larger and larger. Patients may not have a bulge at all. They may just have a heaviness or a dull discomfort in their groin. They don't feel a bulge, but they just know over time it starts to hurt more, and they just can't figure out why it won't go away. For women, it's a little bit different. Vague pelvic discomfort is usually how women complain. They don't really have the protrusion or the bulge like you would normally feel with a man, so it's a little bit more difficult to diagnose these in a woman. And then finally, a kind of telltale sign you usually hear from patients is a patient who's up on his feet a lot, working all day long on his feet, standing up. They'll usually have this pain come on towards the end of the day when they've been up all day long. That pressure builds in that area. They start to feel a bulge or pain in their groin, and then they notice once they go home, lay down, get off their feet, or get in bed, the area will reduce and the pain will go away. That's a kind of a telltale sign of dealing with a groin hernia. So as far as diagnosis goes, the vast majority of these are going to be diagnosed in our office, basically off of you telling me exactly how you're feeling and a good physical exam. About 80-90% of these can be diagnosed with that alone. About 10 to 15% sometimes need us to go further with imaging, and for that regard we'll use either an ultrasound or a CAT scan. Usually it's not needed, but sometimes it is, and especially for these large hernias where patients come in with, like I said, they can be really extremely large scrotums from a bunch of intestines protruding through. Sometimes surgeons will get a CAT scan just to see what they're dealing with and how much intestine's going through at that time. So when should you see your doctor? If you see or feel a bulge in your groin, if it's painful, if you start to feel a pulling sensation in that area, that dull intermittent pain in that area that's just not going away, those are signs that you should come in and just get looked at by your doctor and get a good exam from them. And then when you do see your doctor, you see your surgeon, he's going to really give you two options that we usually have. So for a patient, if you have minimal or no symptoms, we still suggest elective hernia repair for these patients. But if you wish to avoid surgery and you want to hold off, that's fine. We call that watchful waiting. And that basically means that I will go over all the symptoms that you should be worried about, and then if those start to develop, you need to come back in and see us because you're more prone to start to develop a more symptomatic hernia that could be getting worse. So that watchful waiting, the reason we suggest elective hernia repair is because studies have shown that patients that decide to do watchful waiting, 38% of those at 3 years will go ahead and decide to have surgery because they develop symptoms. And then 70% of those patients will actually decide to go ahead and have surgery at 7 years. So if you think about watchful waiting, you say it's minimally painful, or I don't even have pain at this point in time, 70% of those will still have a surgery within 7 years because you will develop symptoms usually. So your repair options, there's two main repair options. You have the standard, like we talked about, open repair. That's your gold standard repair for hernia repairs and the previous surgery history we talked about. This is going to involve making about a 6 to 8 centimeter incision over your groin, right over that hernia itself. Your surgeon will dissect down to that area, find the hernia, reduce the sac that the hernia is coming out through, and repair that by placing a mesh around that area and closing off that hernia defect, and then closing all your tissue above that. That's an open repair through about a 6 to 8 centimeter, depending on it. Sometimes it can be larger, sometimes it can be a little bit smaller incision. And then you have what we call laparoscopic or robotic repair. So if you can see my cursor over here, Laparoscopic and robotics is going to involve you doing 3 little incisions on your belly that are all about the width of your fingertip, like I talked about in the video, and we're able to work from the inside out, basically. So if you think about an open repair, it's working on the outside. If you think about it as a wall, where your inguinal canal is, and that open repair is working on the outside of the wall, you can think about laparoscopic or robotic surgery working from inside that wall to repair it from the inside out, basically. So we go in through the abdomen, blow up your belly, and we actually take down what's called your peritoneum, which is a layer of your abdominal wall, and we're able to look right at the hernia from the inside and reduce it from the inside. And then we lay mesh across the inside of the hernia instead of on the outside. They both have similar recurrence rates, but with the laparoscopic and robotic repair that I prefer to do, your rates of pain are much less, your rates of leaving the hospital sooner are increased, your return to work time is decreased as well. So it allows you to get back to being your normal self much quicker. And what they don't talk about as well is when you do an open repair, when I talk about those 3 different types of hernias in groin, you have femoral, direct and indirect inguinal hernias. Your standardized groin repair is not going to fix a femoral hernia. It's only going to fix a direct and indirect inguinal hernia. Whereas with a laparoscopic or robotic repair, that mesh covers all 3 of those potential spaces. So sometimes this is more indicated in women for sure if they have any kind of hernia, because women are more prone to femoral hernias. So this repair definitely covers all 3 versus the open repair usually uncovers those the direct and indirect inguinal hernias. So complications, we have to discuss this as well. Complications can occur with any surgery. The overall complication rate previously was reported to be less than 15%. I would say it's probably more at 5 to 10% now. Seromas or hematomas, what that is basically a fluid collection where the mesh was placed, and it's basically where when you did an open, these are much more common in open procedures when you're doing an open hernia repair, is basically when you go down, you dissect out that sac, you reduce that hernia, you still have a potential space in that region. So that potential space, even though you have it repaired and you have the mesh down and will not let any more hernia go through, fluid can accumulate in that area, and basically the patient will wake up a day or 2 later, they have a bulge in that area and they think they've had a recurrence of their hernia already, when really it's just a fluid collection that will resorb on its own. That's about 5% of the time. That's much more common in open hernias than laparoscopic or robotic hernias. Other complications that can occur, you can have some urinary retention that may require an in and out of your Foley catheter just for a day or so. They're rare, but it can happen. Surgical site infections, they have it at about 3 to 5%. I've never seen a surgical site infection from an open or a laparoscopic robotic hernia repair, but they do happen evidently. What I most like to talk about with my patients is persistent groin pain rates. That these rates can vary very widely in regards to in the literature saying some that 3%, some at 15 to 20%. It just depends. But groin pain can occur, like I said, that inguinal canal that carries your spermatic cord in men. You also have nerves that run through there as well. These nerves can be injured. They can be injured during dissection. They can be injured with mesh placement or when you're sewing things closed. It's a lot. The persistent groin pain is less with laparoscopic and robotic hernia than it is with open. It's not much, but it's still low. But this pain usually goes away on its own also over the course of a couple months. Some patients will report some numbness in the area, but more than that, usually this will all go away, but there is some people that persist with pain afterwards. And then you can also have some testicular complications and sexual dysfunction with these, but these are all at low rates as well. So postoperative expectations, what we expect from you after the surgery. The vast majority of these are going to be outpatient procedures, meaning you come in the day of surgery, you have your surgery, you leave the same day of surgery. That's going to be probably about 80 to 90% of cases. For those that have larger hernias that are more difficult, require more dissection, some of those will stay overnight, sometimes a day or two, it just depends. You will be expected to be getting ambulating immediately afterwards. We want you up walking, moving around. We don't want you to be sedentary. You'll be on light duty for a couple weeks, and by that we mean light, nothing heavy. So basically I usually tell people you don't want to lift anything over the size of a gallon of milk for about 3 to 4 weeks to give that area to heal, give that mesh a chance to incorporate into the tissue to become with you and make that a strong area of repair. And then people are usually back to work within a week or so. Granted, they're not doing any heavy lifting at work. You can do light duty, you can do a lot of walking and moving around, or if you're sitting, that's usually fine, and people can usually get back to work pretty quickly. As far as prevention goes, you can't really prevent a congenital defect. By that I mean something you're born with, like I talked about for those indirect hernias. You have that there, you're just more susceptible, but you can reduce the strain in those tissues by thinking about different things. You can maintain a healthy weight. If you maintain a healthy diet with that, that allows your tissues to stay stronger, longer period of time. We emphasize high fiber diets, so it's going to be your your fruits like and vegetables and grains, that sort of thing. You want that so you don't get constipated. We talked about that being a risk factor, the strain that comes along with being constipated. So we emphasize high fiber diets. We emphasize appropriate lifting of heavy objects. If you are doing heavy lifting, there's appropriate ways to do that, lifting with your legs, not with your back. And then also, like we said, stop smoking. Everybody's always going to tell you that. It goes for everything in medicine. There's nothing good comes from smoking. This weakens your tissue and weakens tissue repairs as well. So if you are coming in for an inguinal hernia repair, your surgeon will always tell you you've got to stop smoking because that's going to hinder the repair itself and give you an increased likelihood of having a recurrence after that repair. So let's talk about ventral hernias real quick also. We talked about the groin hernias. Now let's talk about the ones on your abdominal wall. So there's several different types, and they're usually described based on where they are on your belly itself. We talked about the umbilical hernia, that's right where your belly button is. You can have epigastric hernias above that. Incisional hernia is going to be a hernia that's going to be from a previous surgical incision. If you had any kind of surgery in the past, whether it was an open surgery, the longer the incision is, the more prone it is for a hernia to go through it as well. And then, and even if you've had laparoscopic surgery in the past, you can actually have hernias from those sites as well. Presentation for these is similar to what you'll have in a groin hernia. Patients will present with a bulge in the area. Sometimes it's painful, sometimes it's painless. Excuse me. They may have just a pressure in the area, but usually with the abdominal wall hernias, you usually can feel those pretty well, regardless of the sex, especially with patients that are really obese. Sometimes it's a little bit harder to feel those, but majority of the time you can feel these on a physical exam and don't need any more imaging. If a surgeon does usually have to get a CAT scan, it's more so to determine the size of the hernia. So if you can see this picture, this is a hernia bulging out on the abdominal wall. This is the defect right here. So the surgeon will want to know exactly how large that defect is, and he wants to know what's coming through that defect. Is it just fat? Is it intestines? Is it a different organ? He wants to know exactly what's coming through there so he knows what he's getting into. And also the size of that hernia is going to determine what you are able to do as far as a repair goes. So the larger the hernia is, sometimes it's too large to do robotically or laparoscopically, and you have to do an open repair in that regard. It just depends on the size of the hernia itself and where it's located. But the vast majority you can get to and you can fix with a robot or the laparoscope as well. So treatment options, just like with a groin hernia, open repair and laparoscopic repair are both available treatment options. The laparoscopic, by that for us, it would be robotics. The open repair is going to entail making an incision over the actual hernia itself, dissecting down and placing that mesh within that. With open repairs, there's over 10 different ways to do an open hernia repair. There's so many techniques out there. It all depends on where you want to place the mesh within the different layers of the abdominal wall. In regards to laparoscopic or robotic repairs, the way we're actually able to do this is this isn't a picture of it, but you actually do 3 poke holes on the side of the belly, on the side of your abdomen that are about the width of your fingertip, and you're able to get the mesh in through those 3 little poke holes, and you're able to prepare it through that, actually within the abdomen, and that's where the robot, when I talked about those wrists, they're able to move like this, the instruments. It really helps you out in repairing it from below, and you're actually repaired from the inside out. You can close the hernia defect and push the mesh in from the inside. You don't have to make any incision over the front side of your abdomen to do this, which is pretty amazing. So like we said, just real quick, the advantages of laparoscopic or robotics over open repair: less post-operative pain, shortened hospital stay, faster return to regular diets, quicker return to normal activity, and less wound infections as well. Postoperative expectations for ventral hernias are going to be similar to the ones in groin hernias. It just depends on the size of the ventral hernia. Sometimes it can get much larger. So if you're going to do a robotic repair of these, the majority of these will actually go home the same day as well. If they're a little bit larger, a little bit more in depth, sometimes they'll stay an extra night. Afterwards, you're going to expect to be light activity, walking around. We want you moving, like we said, and then you'll be on lifting restrictions for about 4 weeks as well. Patients with this usually will get back to work within the first week also. Occasionally, you'll have those fluid collections called seromas develop, but that's almost always with open surgeries versus the laparoscopic ones are much less likely. So just real quick, this is what I'm going to be offering here. Most of these can be done via the robotic surgery, but gallbladder, appendix. We're planning on doing some bariatric surgery in the future. We got to get that all set up. Breast biopsy, breast lesion surgery, endoscopy, EGDs and colonoscopies, splenectomy, hernia repairs, skin lesion removal, stomach surgery, thyroid surgery, colon surgery, and hemorrhoids. We want it all. So we're looking forward to your business. And then this is just one more picture of my kids. That's Caleb on this one. He's 5 years old now. He likes fishing more than I do. He's got more patience than I do. This is my boys at Halloween, and then it's my younger son, Tyler. Caleb starts school tomorrow, actually, I think, and Tyler starts Mom's Day out, I think, as well. So that's my family. I'm looking forward to starting in Cullman, and I can't wait to meet some of you guys.